strategies to close large ASD with deficit trims. I think Dr. Sivakumar requested because we thought he would be the right person to go. Please come. Thank you.
We are going to discuss for the next around 15 minutes or so about device closures and large ASDs with deficient margins. Primarily this talk will be all about utilization of the Amplatzer or Amplatzer-like nitinol-based self-centering devices. And if you see, when we started off with the closure of the atrial septal defects, the conventional indications were a defect measuring up to a maximum of around 34 millimeter, and it should have rim of at least 5 millimeter all around, with the only exception being the anterosuperior retroaortic rim can be deficient. But with increasing expertise and newer techniques, even defects up to 40 to 42 millimeters are being closed, and even defects with deficient margins are being closed. So with this background, I'm going to talk on 3 issues. If you see the talk, closure of ASDs, the strategies, in those with deficient margins. So we need to know what is a margin. Number 2, we need to know what is deficient margin. Number 3, we need to know what are the strategies. So the first 5 minutes is going to be how all of us can talk similar on what is a margin. And second is what is deficiency of a margin. And third is what is the strategy. A small update on what are the margins. We have, is a marker? Yeah. We have, if you are cutting off the right atrial free wall and visualizing the atrial septal defect, superior vena cava and inferior vena cava are above and below, so this becomes the superior and inferior margin. All the pulmonary veins keep draining on the posterior wall, so this becomes the posterior margin. And anteriorly, if you see, on the upper portion, that is anterosuperiorly, you have the aorta, and anteroinferiorly, you have the AV valves. So, in other words, we have 5 margins: a superior margin, an inferior margin, an anterosuperior aortic margin, anteroinferior mitral margin, and a posterior pulmonary venous margin. This is a similar view, a 3-dimensional echocardiogram. The same, a chopping off of the right atrial free wall has been done. So what is visualized is the superior vena cava. What is visualized here is the inferior vena cava, the limbus of the fossa ovalis, a fossa ovalis ASD. You see the aortic valve leaflets here, and this is the aorta. So this becomes the anterosuperior retroaortic margin. You see the marginal attachment of the septal tricuspid leaflets here, and this is the AV valve margin. So this is the anteroinferior AV valve margin, anterosuperior aortic margin, superior SVC margin, inferior IVC margin, and posterior pulmonary vein margin. The reason why I am going for this is we all need to talk in the same language about what is all the margins. So how do we identify these margins on a transthoracic echo? An atrial septum can be visualized from 3 areas. One from upper end of the chest, parasternal short axis view, where the image will go down. From the apical view, where the image will go from the apex up. And the third is subxiphoid view, where the image will go from the subxiphoid area. Once again, a recap. We have 5 margins: anterosuperior, anteroinferior, inferior superior, and posterior. Now, from the apex, when we are viewing, we are cutting the heart as a slice from the apex all the way up. So if you see, what we are cutting at the most inferior portion of the cutting plane is the anteroinferior mitral margin, and what we are cutting at the most superior plane is the posterosuperior margin. So this is what is represented here. What we are seeing on the apical 4-chamber view is the mitral margin and the posterosuperior margin. Now we are moving the probe. So if I put this one image, this is the anteroinferior mitral margin and the posterosuperior margin. If I move the probe from the apex onto the parasternal short axis, so here we are going to cut the heart from above downwards, and so what we have in the front is the anterosuperior retroaortic margin and the posterior margin. So this is the parasternal short axis view, aorta. So this is the anterosuperior retroaortic margin, and this is the posterior margin. So now what we have made in the atrial septal defect is 2 cuts, one starting from the apex up, one starting from the aorta down. So if you ask what is the margin on a parasternal short axis view, it is the aortic rim or the anterosuperior margin and the posterior margin. The third cut is from the subxiphoid. Subxiphoid, we have got an opportunity to cut it on a coronal plane and on a sagittal plane. If you cut on a coronal plane, whatever you are seeing on the leftward end is the posterior margin. Whatever you are seeing on the rightward end is the anterior margin. So this is the coronal plane cut. When I mean coronal plane cut, the marker of the probe is bang on the left side. And there is another way in which we can cut. We can cut it longitudinally. This is the short axis cut, where the marker is facing posteriorly, touching the skin. So here, we cut the superior vena cava and the inferior vena cava. So this becomes the superior margin and the inferior margin. So all the 6 margins are now covered. So in a subsequent short axis, if you see, this is the superior and this is the inferior. Just a short recap. From parasternal short axis, you are going to see the retroaortic rim. From the apical forechamber, you are going to see the anteroinferior rim. Both these are going to see the posterior rim. In one view it will be the posterior superior, and one view it will be the posterior inferior. And from subxiphar you are going to visualize the superior and inferior margin. From this we go on to the transesophageal echo. This is the heart, we put in the probe, and this is the probe. The probe is going to cut in various views. This is a 0 degree cut. This is a 90 degree cut. So 0 degree cut is actually a horizontal slice of the heart, 90 degree cut is a vertical slice of the heart. In between you have a 45 degree cut, which is a oblique cut, which starts from the anterosuperior and goes down to the posterior-inferior. Let's just see these 3 views in little bit more detail. So this is the same view magnified. Now, in a 0 degree cut, we are cutting transversely across. So whatever you are seeing on the right hand side of the probe, of the image, is the anterior margin, and whatever you are seeing on the leftward side is the posterior margin. It depends on whether you pull up the probe to see the aorta or push down the probe to see the AV valve. So all these things are going to be the anterior and posterior. The 45 degree view, this is the oblique view. It starts from the anterosuperior and goes down to the posterior inferior. So always at 45 degree you will see the aorta, and behind the retroaortic margin, and then the ASD, and then what you see is the posterior inferior margin. And the last view will be the 90 degree view, which is a vertical slice of the heart. You'll see the superior vena cava, you'll see the inferior vena cava, and whatever you are seeing is the superior and the inferior margin. What we have introduced is the margins. We all have to talk in similar language. Second question, what is deficient margin? Once we identify the margin, identifying a deficient margin is much more easier. An example of what is a deficient aortic margin or deficient anterosuperior margin. This is one of the common margins to be deficient. Any defect more than 20 to 25 millimeter will often be associated with an absent retroaortic margin, and this is one of the margin which we can afford not to have at all for performing a device closure, because the device is going to flare on either sides of the aorta and get a very stable position. About the question of whether a flared device is going to cause a harm to the aorta, a large number of years of experience has come, it doesn't harm the aorta. The only issue is, in very rare instances, because of compression on the aortic root, it may produce a trivial grade 1 aortic regurgitation, which again in the long term is not going to progress. So this is the deficient retroaortic margin. This is the deficient posterior margin. You see, this is a 0 degree cut, and whatever we are seeing on the left hand side is the posterior margin. Absolutely there is no margin at all. So this is how a posterior margin deficiency will look. On the left hand side of a transesophageal probe on 0 degree, you won't find any margin at all. Let us see. So this is a deficient posterior margin. This is the subxiphal short axis view for a small child. You see, this is the inferior vena cava, and this is the deficient IVC margin. See that the color is skirting along the posterior wall of the inferior wall of the heart. So this is an inferior margin deficiency, and on a transesophageal echocardiogram in a 90 degree, where the inferior margin is supposed to come here, there is no margin at all. So once you know the margins to identify what is deficient margin, it becomes easier. Now, before going into the strategies, let me tell you, if you are having an anterosuperior rim deficiency, that is an aortic rim deficiency, as I told you earlier, the device is going to flare on either side of the aorta and is going to give you good stability, and so that is not a contraindication. When it comes to superior margin deficiency, superior vena caval rim deficiency, it's a very short rim, and in that place, if there is a deficiency, once again getting the device into a very stable position is very easily assured, but that is the place where the device may erode towards the roof of the left atrium, or sometimes towards the aorta edging onto the roof of the left atrium, and these are the cases where erosions have been reported. So if you are having a superior margin deficiency or a superior SVC margin deficiency, these are the patients where you'll be able to position the device well, you'll be able to release it, the device will not get embolized, but you need to remember that these are the patients which has to be on long-term follow-up to identify whether they are going to get onto perforations or erosions. About the posterior-inferior rim deficiency, it's very mandatory to have at least a nubbin of tissue on the posterior-inferior margin, and if you don't have any posterior-inferior margin at all, it's not going to be possible. But you see, the posterior-inferior margin is a long arc of this circle. It starts all the way from somewhere around 90 degree, and I mean 6 o'clock, to going all the way up to 11 o'clock if you are viewing it from the right atrial side. And not all the patients will have an entire posterior-inferior rim deficiency. It's going to be some people with posterior margin preserved with inferior margin deficiency, some with inferior margin preserved with posterior margin deficiency. So these are the cases where all these strategies are going to work. The fundamental strategy in a deficient margin, when you want an Amplatzer device or an Amplatzer-like device to open up, what you want to have is a left atrial device open up, come exactly on line with the interatrial septum and stay on the left atrial side. Then you open up the waist, then you open up the right atrium, and until that time is completed, the left atrial disc should not prolapse into the ASD. So this is what we desire. But when the ASD is large and when the margins are deficient, the left atrial disc prolapses through the ASD even before the formation of right atrial disc in the right atrium. So our prime strategy is to prevent this left atrial disc prolapse into the ASD. What are the things that we can do? This is going back to history. In the initial about 5 years or so, when the Amplatzer devices were used in the 95 to 2000, the primary strategies were use some sort of gadgets to prevent the left atrial disc from slipping through, which means you put in a catheter along the sheath to go all the way into the left atrium, and this catheter is going to hold the left atrial disc within the left atrium and prevent it from slipping. Sometimes it may be a stiff guide wire that will go through. Sometimes it will be a dilator passed through the other venous axis which will go through. So aim of all these three, put something into the ASD, make it enter into the left atrium and prevent the left atrial disc from slipping through the ASD. So this was the preliminary strategy. This worked reasonably well when the ASD devices were between 25 to 30, but when the device is very large at 38, 40, and the defect is very large at 36, 34 and all, these strategies didn't work. So then came the second strategy. These were the strategies that were followed in the early 2000 to 2002. Modify the sheath tip so that the angle at which the left atrial disc approaches the interatrial septum is modified. We already saw, if the ASD device left atrial disc is coming exactly en face with the atrial septal plane, then we are very happy, but it doesn't happen all the time. So you need to modify the sheath tip in some way that the device will come en face. Now let us see what are all the modifications that came in the years 2000 to 2003 to 2004. One of the modifications was a double angle given, what is called as the Locke-Harsdorff sheath, named after Harsdorff and Jim Locke. This used to be a very, very useful sheath in those days because some of the retroaortic margin deficiencies, the device was able to tilt the device, left atrial disc, a little bit away from the aortic margin, making it easier, but it didn't work in all the patients. Then another modification that was made by Larry Latson was to have a sheath cut. So what he did was cut along the undersurface of the sheath, and let's see how it works. When you are cutting along the undersurface of the sheath, your device doesn't come perpendicular to the sheath, but comes sort of oblique to the sheath. Let us see a total example. This is a normal sheath with a circular orifice, and when it comes with a circular orifice, the left atrial disc is opened in the left atrium. As you are slowly pulling out, the left atrial disc prolapses the retroaortic margin. This prolapse is because the device is coming perpendicular to the sheath. Now you need to make it oblique. So what is done is here, the undersurface of the sheath is cut. This is called as the Boosfeld tip modification or the Larry Latson's modification. And you make a cut so that the device comes at an oblique angle. Once again, this strategy was working in few patients, but didn't work in all. The third strategy that came in the years between 2004 to 2007, where don't allow the left atrial disc to come near the interatrial septum at all. keep the left atrial disc as far away as possible from the intra-atrial septum. Only if it comes closer to the intra-atrial septum, it is going to prolapse into the ASD. So don't make it come closer at all. So what were the strategies? Either deploy it within the pulmonary veins or deploy it far high in the left atrial roof, so that the left atrial disc is deployed in either of the pulmonary veins or hitched against the roof of the left atrium, and it prevents its contact with the intra-atrial septum. So the strategy goes like this: you enter into the left atrium and deploy the left atrial disc as a ball within the left atrium, and release the right atrium and allow the left atrial disc to pop in back. Now this is how it will be. You just put into the left atrium, pulmonary vein, and make it like a ball so that the device doesn't come out, and by the time you release the right atrial disc and then allow it to slowly fall back. This was deployed in either the left upper pulmonary vein or sometimes in the right upper pulmonary vein. So basically don't allow the device to come into the atrial septum at all, and try to deploy the whole thing in the right upper pulmonary vein, create like a ball, and then try to release the right atrium and make the the device that was deployed in the pulmonary vein to fall back later, like this. But the third strategy was you open up the device within the left atrium, give a clockwise torque and hitch it against the roof of the left atrium, so that it just hugs the roof of the left atrium and never comes closer to the atrial septal defect at all, and then try to deploy. Now all these things do have a small problem. We all had a perennial fear on whether these sort of deployments are going to abrade, erode the pulmonary veins and cause a trauma to the pulmonary veins and cause a trauma to the left atrial roof, especially in the smaller children where all these structures may be very thin-walled. The fourth strategy that came in the last about 5 years is use a balloon to prevent the slippage of the left atrial disc through the atrial septal defect. This was conceptualized in our own country by Dr. Bharat Dalvi. The principle is like this: you put two wires across, and through one of the wire take the sheath for deploying the device. Through the other take a balloon. This balloon is called as the Boston Scientific's equalizer balloon, which is basically like a latex balloon, a spherical balloon, which can be opened up as big as up to 40 millimeter. It's available in two sizes, 27 and 33. A 33 can be inflated even up to 40 millimeter. And once you have opened out the whole of the balloon across the atrial septum, the balloon, inflated balloon, prevents the device from prolapsing through the ASD. And you open up the whole of the LA disc within the left atrium, and this disc is not prevented from entering into the right atrium because of the large balloon occupying the plane of the atrial septal defect. And then open up the entire right atrial disc on the other side of the balloon, and then start slowly collapsing the balloon so that the two devices hug the atrial septum in the perfect manner. This is how it goes on. You open up the left atrial disc with the fully inflated balloon, and once you are across, slowly start deflating the balloon. And as the balloon gets deflated progressively, you push the cable so that the right atrial disc goes and hugs the intra-atrial septum, and a perfect position is achieved. So this is called as the balloon assisted technique. The basic principle was to have a large balloon across the atrial septum to prevent the left atrial disc from collapsing into the right atrium. And sometimes when this equalizer balloon is not available, you can use an AGA sizing balloon, you can use a large tie-shack balloon like 25 millimeter tie-shack balloon or 28 millimeter Z-med balloon. Any of the balloons are acceptable as long as the balloons are shorter in their length. To come to a summary of the techniques, the first four years we were using certain materials to prevent the left atrial disc prolapse, like the catheter, guide wire, sheath dilators and all. Then in the next about 3 years, we started modifying the sheath tip with either Lock-Hausdorff sheath or the cut tip, that is the Latson's method. Then in the subsequent around 3 to 4 years, we started using this technique where the left atrial disc is made to stay as far away from the intra-atrial septum as much as possible by deploying it either in the right upper pulmonary vein, left upper pulmonary vein or left atrial roof. The problem with all these techniques, the first one works well when you are having an ASD within 25 to 30, but not when it is 35 or 40. The sheath tip again works when the ASD is relatively smaller. The pulmonary vein technique works, but then you have a fear on like a large 38 millimeter device being entirely deployed in a small pulmonary vein and then pull it back. We are having concerns about what this radio frequency for atrial fibrillation is going to cause for the pulmonary veins, and just imagine a macro device of 38 millimeter just going and like occluding the pulmonary veins for about 15 to 20 seconds before it's being deployed. So we do have a concern about all the thin-walled structures, the pulmonary veins and the left atrial roof. And use of balloon to prevent the disc slip with either an equalizer spherical balloon or a oval AGA or tie-shack balloons. This came up in the last about 5 years. The most reliable single technique for closure of atrial septal defect with all deficient margins is balloon-assisted technique. I wanted to make it very simple. The reason being, when you are bombarded with about 12 different techniques, in one particular given patient, what to use becomes a query. We are confused. This is one technique that you can use. An ASD that is measuring more than 25 millimeter and going up to as big as even 41 or 42 millimeter. And if you are choosing a device, anything between 30 to 46, a balloon-assisted technique is going to work in the most consistent, most reliable manner. It's a 46 millimeter ASD device being deployed with the balloon-assisted technique in a patient who had a 41 millimeter device. It can be done with reasonable degree of reproducibility. Each time we do it, the device will go and sit there properly. The take-home messages, I wanted all of you to talk uniformly when we talk about ASD margins. We should very clearly define what is antero-superior retroaortic, what is antero-inferior mitral margin, what is inferior IVC margin, what is superior SVC margin, what is the posterior pulmonary vein margin, and how to identify in the various standard thoracic views and standard transesophageal views. Once we identify the margins, it becomes very easy to say which margin is deficient. And strategies, we should know that people have started using various strategies right from 1997, 98 onwards. But in the last 4 to 5 years, the method that consistently works is the balloon-assisted technique. And it is sort of universally acceptable, irrespective of whether you have an anterior rim deficiency, posterior rim deficiency, inferior rim deficiency, whether it is a defect of 25 millimeter or a 41 millimeter, all the procedures, balloon-assisted technique is going to be reproducibly be useful. Thank you.
Sivakumar, I wanted to ask you, is this balloon-assisted technique works in any deficiency, or this a particular type of deficiency of the rims only? Or if in that case, there is no point in mentioning about which deficiency is, which all is deficient or anything.
The basic principle of a balloon-assisted technique is to prevent the left atrial disc from collapsing through the atrial septal defect into the right atrium. By the time the right atrial disc is fully opened up, the left atrial disc should not collapse back. This technique, since the balloon is going to straddle across the entire circumference of the atrial septal defect, it works in posterior rim deficiency, it works in inferior rim deficiency, it works in anterior rim deficiency. The other methods that were tried, for example, a left upper pulmonary vein approach, a right upper pulmonary vein, they are all more and more useful for selected rims. A right upper pulmonary vein will be more useful when you are having a retroaortic anterior rim deficiency, because the angle at which the device is going to come is not going to be hitching against the retroaortic deficient rim at all. Whereas balloon-assisted technique universally works for all rim deficiency. So to make it very simple, I say follow one technique, whatever be the rim that is deficient, this is going to work. But we should remember, if there is a confluent large postero-inferior rim deficiency, imagine the diagrams that we saw, the en face view of the atrial septum. If you are going to have a deficient rim starting from 10 o'clock position all the way down to 5 o'clock position, the entire posterior and inferior rim is deficient. Obviously, none of the technique is going to work. So you need to choose your patient. You need to identify, only posterior rim deficiency, only inferior rim deficiency, it's very likely to work. And this technique is quite useful. In general, I would say, for people who are doing a little bit less number of cases, consistently use them whenever you are taking a device more than 30. The reason is, once you keep pulling back the device 2-3 times by the routine conventional technique, whatever be the flimsy, thin margins, they all get torn by the repeated manipulations. And finally, it makes the procedure almost non-achievable. So try to achieve it in one go. The second reason why we need to make the procedure very short is, it has been found that by using the microembolic signal detection in the carotid arteries and in the brain, they have detected that the longer and longer a procedure is going on, the more and more of high intensity signals, hits, are going to be very high if you keep manipulating the atrial septal defect for about 20 minutes or 30 minutes. So try to make the procedure as brief as possible. Electively take a balloon assisted technique once the device is more than 30, because the procedure is going to be very short. In first go, you'll be able to deploy and come out.
So if you were to use a Taishak balloon for a large defect, what sort of a balloon would you use?
We have to use only a 25 millimeter diameter balloon. A 25 millimeter balloon comes in various lengths. It comes as short as 3 centimeter and as long as 6 centimeter. You have to use only the 25 into 4 at best. It should not be a very long balloon straddling all the way from inferior vena cava up to the pulmonary vein. It should be as short as possible. I'm telling, equalizer is a very good balloon, but only if it is not available in your shelf, then go for these things. Don't take it as a primary balloon. Amplatzer sizing balloon is very often available in various cath labs, and so probably that is another acceptable alternative. But equalizer is a very good balloon because it is a spherical balloon. Don't use some of these other spherical balloons like the Coda balloon or any other. The stent grafts will all have an inflation balloon. They all will be spherical. Don't use them because they are very, very soft. You need a little bit of strength. So equalizer is one balloon that is having sufficient strength. It comes in two sizes, 27 and 33.
Also, Shiva, when you
ask one question?
Yes.
How do you ensure that this balloon which you are using for assistance, should it go into that portion of the septum which is deficient, or you don't care?
On the transesophageal echocardiogram, the balloon should straddle the atrial septal defect. The inflated balloon should straddle the atrial septal defect, so that you are almost sort of stopping the flow. The inflated balloon should be just bang across the atrial septal defect. So you need to ask one assistant who is on the other groin from where the balloon has gone to keep pulling it or pushing it till the time the balloon is exactly astride the AST.
Say, if you use this technique, still in how many cases you would declare it as a failure? Do you have such situation? Or?
The chances, the times at which I have failed with a balloon assisted technique had been only in the 44, 46, when I was trying to use the 44 and 46 millimeter very large devices on patients with already, the defects measuring almost up to 40 or 41. Not in the regular, like up to 40, it is consistently reproducible. 40 or 42 devices, it's consistently reproducible. It's a very good technique. I'm reinforcing it just because the number of failures will be substantially lower if you are using this.
Thank you, Shiva. I think that has been very lucid discussion.